I will get started just with some housekeeping and some introductions across the board. But if you would, please take this time to familiarize yourself with the WebEx platform. As attendees, you will not be able to turn on your camera or microphone, so I encourage you just to navigate to that chat so you're able to see any questions or comments that come in from others. And I do ask that you take this time to introduce yourself, your credentials, and where you practice in the chat, just so we have a better understanding of who's online with us today. And you may have some personal connections online with us. My name is Bridget Sweeney. I'm the training coordinator for the Maryland Addiction Consultation Service, and I'll give a little more info about what we do at MACS, but I will first introduce and thank our county partners for being online with us today. So we are partnering with the Anne Arundel County Health Department, and the Anne Arundel County Department of Health offers buprenorphine access and services through our Road to Recovery program and through our Maryland Mobile Wellness program. They travel to different areas throughout Anne Arundel County to connect people to buprenorphine in the community, and the department strives to connect participants with easy access to buprenorphine and wraparound services through several programs to help our community and clients. So Jason LaSalle is the representative from Anne Arundel today. If for any reason he cannot put his info into the chat to all attendees, I will copy and paste it. I know he sent it to me directly earlier, so I'm happy to share that. We are also partnering with the Baltimore County Department of Health's Opioid Misuse Prevention Program team. So as advertised in the MedChi digital newsletter, the Baltimore County Department of Health is pleased to inform its prescribers of the return of the BCDH Academic Detailing Project. This initiative, which was on a hiatus since the COVID-19 epidemic, is an interactive, in-person educational outreach effort to optimize clinical decisions, improve patient care, and share valuable resources. All Baltimore County prescribers are encouraged to participate to better aid patients and utilize available resources. And for more information, you can contact Adrian, and I'll make sure Adrian's information is put into the chat. A few other upcoming changes that you all should be aware of is over the holiday break on December 29th, 2022, President Biden signed the fiscal year 2023 omnibus, passing the Mainstreaming Addiction Treatment and Medication Access and Training Expansion Acts. These bills were passed to expand access to buprenorphine for the treatment of opioid use disorder and normalize and enhance substance use care across healthcare settings. MACS is monitoring guidance from the state and federal agencies closely, and we'll update this page when we have more information. I'm making sure that one of our team members just puts that information into the chat so you can access it. And the resources on that page offer information about the omnibus, the bills, and the implications for healthcare providers and programs. A lot of the details around that program is still up in the air, so we are navigating that at MACS and are happy to answer any questions you have. I think that would be a great reason to call our warm line, and I'll get a little more into our warm line services in one moment. And then just something else to keep in mind is coming up in February for a lot of our continuing education events, we will be switching to a new learning management system. I know that we have a lot of frequent flyers for our MACS webinars, so this learning management system will make it easier for you to access all of your certificates and all of our previous courses in one place. So please just stay tuned, make sure you're signed up for our newsletters just so you have information about accessing that portal and being able to sign in and everything. That way it's a smooth transition for you and you're able to get the most out of our educational resources. I am just going to give an overview of our MACS services now. So all of our services are completely free because we are state funded. Those services include a warm line open Monday through Friday, 9 to 5. That warm line is open for you as prescribers to answer any questions you have. They can be as patient specific as you'd like, but they can also, as long as it's de-identified information, but they can also be broader questions just about best prescribing practices, best practices in treating any type of substance use disorder. And even if it's just, you want to just ensure that you are giving the best care and just run your care plan past our consultants, they're happy to listen to that as well. We also offer webinars such as today. We usually try to do those during the lunch break to accommodate your busy schedules. I know sometimes it's hard switching from patients morning patients to afternoon patients, but we do think that this is the best time for you. But we also just offer a wide range of didactic presentations to make sure that we are staying up to date with latest changes, such as today's webinar. We also offer collaborative echoes, which happen once a month. We have 3 different types of echoes going on right now, and there's one for OTPs, there's one for primary care providers, and there's one for those who treat maternal opioid misuse or just OBGYN patients. So we will put more information about that in the chat as well. Once again, all of our services are completely free. Please reach out to us. And finally, I'll just give a little overview of today's webinar and how it will work. As you may have noticed, today's webinar is being recorded. That recording will be up on our website within 1 business week. You will also receive a copy of the slides as well as more information about Max to the email that you're registered with by the end of the day today, so please look out for that. In a separate email from Qualtrics, you'll receive a link to the evaluation survey. Once you fill out that evaluation survey, please allow 1 business week for us to send out your certificate. We do process attendance manually, so it does take a little bit of time just to make sure everyone is getting the credit that they should. So please look out for that. Once again, all that information will be going to the email that you registered with. If you have questions throughout today's training, you can enter those into the chat. Your microphone and camera will be off for today's training just because we anticipate larger crowds for webinars. So please make sure you can access that chat and send any questions or comments you have throughout the webinar, and I'll read those to Dr. Merritt when there is a break. Finally, I'll introduce our speaker today. Today's speaker is Dr. Sarah Merritt. Dr. Sarah Merritt is triple board certified physician with ABMS qualifications in anesthesiology, pain medicine, and addiction medicine. Currently, Dr. Merritt is active as a volunteer in the medical community in addition to her medical practice. She was appointed by the Maryland Department of Health and Mental Hygiene as a member of the Technical Access Committee for the Maryland State Prescription Drug Monitoring Program, also known as the PDMP. She is also the co-chairperson of the Legislative Council for MedChi, the Maryland State Medical Society, and a member of the MedChi Board of Trustees. And most importantly, in my opinion, she is one of our expert consultants who can answer any of your questions about pain management and beyond. We are very lucky to have her, and we're even luckier to have her to be our presenter for today's topic. So Dr. Merritt, I will turn it over to you. Please feel free to get started.
Thanks. That's super sweet, Bridget. Appreciate it. All right. Well, thanks everybody for joining us to talk about the CDC opioid prescribing guideline updates. Bridget was asking my preferences in terms of questions, and if you have questions, feel free to put them in the chat, and we may pause for them if the time seems right. I'm happy to make sure we handle questions as we go along. This is a big topic, but so that you don't have to read the 200-some pages of the CDC opioid prescribing guidelines, maybe I can update us all with where they are. This is a hot topic, and really even, I've been a Max consultant for a couple of years, just based on my experience treating patients with pain and addiction. And when I knew that these guidelines were going to be revised, I asked, I said, hey, we want to make sure that we cover this topic. And so here we are. This is the first time that I'm giving this this talk. So hopefully we'll be able to enlighten you a little bit, but please jump in with questions and things, and try to address this. Let's see, there we go. So here's my Max slide. You heard a little bit of this from Bridget already, but again, Max has services available for you, for your patients. Max is here to provide support to prescribers and their practices, as well as pharmacists and healthcare teams addressing the needs of patients with substance use disorders and chronic pain management. And so when patients, when prescribers have challenges with difficult cases, feel free to reach out to us. That's what we're here for, and we have funding for it. There is CME available, and so in order to do that, we need to make sure we have a couple of learning objectives and some learning points that we make clear at the beginning. And and get to in the talk. We want to make sure that in this talk that we make sure we all understand what evidence-based medicine is and who does a clinical guideline apply to. We're going to talk about different factors that have contributed to the CDC revising the guidelines that were put out originally in 2016, and then specifically to name a couple of the updates. So why do we even need a CDC guideline in the first place? Well, in 2016, I think the CDC was recognizing that there was a lot of prescribing of opioids for chronic pain in the US. And chronic pain itself is a huge burden on patients and on our society. At least 11% of Americans have daily or chronic pain, and it may be as high as 20%. Probably about 25% of patients who have chronic pain have taken an opioid in the past 3 months for pain. Pardon me, I've got a little throat tickle, so I'm going to have some water during this. And opioids probably are taken on a regular basis by maybe as many as 3 or 4% of US adults, depending on the statistics that you look at. And so in this setting where maybe from the late 90s into the 2000s, opioid prescriptions were rising and opioid deaths were rising. And those things were, I think related. And actually, there's an excellent book on this topic called Dreamland by Sam Quinones that many of you may be familiar with. But if you're interested in kind of that dynamic of the early part of prescription opioids becoming more prevalent and maybe some of the poor prescribing practices or even non-medical prescribing practices, and then also how that in some places more heroin, more illicit opioids becoming available in, say, in certain states, non-urban states where there had never been heroin, suddenly there was. All of this has led to higher numbers of opioids being taken on a regular basis and then higher numbers of death. So in 2016, related to more and more Americans being prescribed opioids for chronic pain, there really wasn't a national guideline out there. There were some guidelines, and there was some information in the literature, certainly. Excuse me. And Washington State, for instance, has a statewide workers' comp agency that has very good data on opioids and on what's happening with their patients. They put out some early guidelines. The Department of Defense has done their own guidelines, but these are not entirely consistent. And, hey, I'm a prescriber in Maryland. How does that apply to me? Would be a relevant question. There are some national guidelines. And at the time of, maybe 2016, the most recent national guidelines were from 2010 from the American Pain Society. And it was really in 2010 that out of Washington State, there was publication about how in some studies looking retrospectively at patients prescribed various tiers of milligram morphine equivalents, they were able to show that patients who did have higher dose opioid prescriptions had higher dose of opioid related problems like substance use disorder or overdose and death. So clearly those were problematic. That was a big finding. And actually, we'll see, and I've got a slide in a moment here, after 2010, prescribing did begin to decrease, I think somewhat, on the heels of that information being more prominent. And so, how do we practice with an evidence base? And there's a specific definition here. This paper itself by Sackett is cited pretty frequently because this is the kind of the definition that's out there, that it's a conscious use of the best evidence in making decisions about the care of the individual patient. Now, in no place does this say that you're going to only follow a recipe, that you're only going to follow a rule, that you're going to see everything as black and white. But no, in evidence-based medicine, that, and this is hopefully what we do as clinicians and as prescribers, taking our knowledge, our training, and our experience, all of this into bear in the care of a patient. And so I think it's important to acknowledge that, because you maybe here because you're aware that the CDC guidelines in 2016 did have some specific recommendations regarding, say, dose limitations, and did suggest caution around certain milligram morphine equivalent numbers. And what we have seen come about, what we've seen come about is that as the prescriptions and things have, what we've seen come about as we've, I'm sorry, I've lost my slide train of thought here. I've got an extra screen going that's got me. I'm going to start over on the 2016 guidelines. We talked about evidence-based medicine. Let's just catch up on where we are now relative to 2016. And I thought this was a pertinent graph to show. This is the book I mentioned earlier, Dreamland by Sam Quinones. And again, that just a reminder, where were we in 2016? And by the way, the 2016 published guidelines were written really earlier than that. And so the opioid epidemic has continued to evolve. Nonetheless, good medical practice is good medical practice, and we want to prescribe opioids cautiously. So this is what I was referring to earlier that we've seen since 2010. This is a slide from the CDC that opioid prescriptions have been in decline. If this graph included times before, you'd see opioid prescriptions rising prior to 2010 in the United States. And then since then, they've been decreasing. In about 2021, 22, we're probably around year 2000 levels for opioid prescribing is the information that I've been given, and about 44% decreased since this 2010, 2011 peak. And nonetheless, unfortunately, because of the illicit fentanyl that is so deadly, despite the fact that we probably are doing a little better in terms of fewer tighter opioid prescribing criteria, unfortunately, overdose deaths are still not under control at all. And so why did the CDC come to revise these guidelines? So the 2016 guidelines, I mentioned just a little what they have in them. I think that a lot of us here are prescribers and may know that they mention some dose numbers to be cautious around. And those dose numbers being mentioned specifically was a big factor that that allowed insurers and some state bodies to really kind of misapply these guidelines for their own use. And so what we've seen since 2016 is some practices would say, hey, we're no longer treating chronic pain at all, or a practice might, set a dose limitation or cut patients off entirely. And on the one hand, certainly as a prescriber, I think it's reasonable to, choose how you're going to practice. But where the CDC guidelines of 2022 has gotten to is really trying to emphasize that if a provider determines they want to taper a patient, that they will work with them collaboratively over a period of time versus forced tapers or large changes by 25 or 50% at a time. In addition, really those guidelines, and I think those guidelines had a title, just that, again, that they were the CDC. excuse me, opioid prescribing guidelines for chronic pain. Now the title's been changed a little bit, and really they're including a little more about the other treatments and options. So after those guidelines came out in 2016, this was an article that was released June of 2019 to directly address this issue. And I've got a little quote from it, actually. And so these authors of this article from the New England Journal, Dowell, Hayrick, Rich, and Roger Cho, are authors of the CDC guidelines. And so they took their time to write this article as sort of an alert that they saw harms from the misapplication of the CDC guidelines of 2016. And so they said, since the CDC released its guideline for prescribing opioids for chronic pain in 2016, the medical and health policy communities have largely embraced its recommendations. A majority of state Medicaid agencies reported having implemented the guidelines in fee-for-service programs by 2018, and several states passed legislation to increase access to non-opioid treatments. Indeed, the guidelines uptake has been rapid. And they go on and on. But kind of this idea that these guidelines have been taken up by the insurance community, which they were never intended for, that they are a clinical practice guideline and not an insurance, and not just a CDC guideline that is for everybody. And so this is the retitling that was done to help emphasize that these that these guidelines are for clinicians. And so this is just copy paste of what the two titles are. So the CDC guideline for prescribing opioids for chronic pain is the first, or is it a clinical practice guideline? And again, we've gotten to a place of it now being the clinical practice guideline. So what is a guideline anyway? And so this is kind of back to that same concept earlier, regarding evidence-based medicine, that it's like the rational use of information to apply to your patient. The guideline is a recommendation intended to assist the provider, the prescriber, to make an informed decision. And so on the one hand, you hear guideline and you might think, well, that's a hard stop or a no-go. It's guiding you to stay in the line. Well, no, in the context of a clinical practice guideline, a guideline is meant to assist and is meant to maybe help people find the middle and where most of our care should be within a certain boundary. However, if we all take care of patients, then we know that there are always those things that fall outside of the usual. So I did want to put this slide in, which shows just the guideline, the process around the guideline revision. So there was, recognition by 2018 that a revision was necessary. And so committees were formed. The OWG is the opioid work group that did a lot of the feedback for the authors, and the opioid work group consisted of many stakeholders, pharmacists, prescribers from different disciplines and with different degrees and qualifications. And so they met a lot, they wrote it up. They also put it out here for a comment period, which I think is important also. This was intended to be part of the process, is that federal comment period that stakeholders are able to give feedback. And so briefly, here are kind of bullet points of the guideline changes, and then we're going to kind of go through these and the specific. There are 12 kind of bullet points of the guidelines. The document itself is around 200 pages, but really just to focus on what are the changes and the updates. If you're here, you're probably at least a little familiar with opioid prescribing for pain. And so we're just going to focus on some of the nuance. All right. And so the clinical audience is broader in scope. So if I was doing a prior authorization or a call or something with somebody who says, well, doctor, the CDC guidelines say, that you have to only prescribe 90 milligram morphine equivalents. With the 2016 guidelines, I could say, well, I'm not a primary care doctor and they're intended for those doctors. That was one of the ways as a pain specialist, I would try to, get around it in a challenging situation. If I had a patient who I believe needed more than, say, a 90 milligram morphine equivalent threshold. Now, I think the clinical audience is broader, which is really good because we all need to be practicing, be good stewards of opioid medications and doing our best. And so I think really this is, I think it really applies for outpatient settings. There's really not a part here that says like, say, pain specialists are excluded. I do think it really, on the one hand, while it is, geared more toward primary care clinicians, really it's about, it's about including all the prescribers so we can be good stewards of our opioids and taking care of our patients. There's also a differentiation between initial and ongoing therapy. So initial therapy would be thinking about like, oh, if I'm going to think about starting an opioid for a certain patient, continuing would be, hey, this person comes to me for a consultation. They're already taking 120 milligram morphine equivalent. What do I do with that? And so frankly, they're not the same thing. And so the guidelines have attempted to delineate between that. So upon initial treatment with prescription opioids, certainly there are considerations that will continue. And for patients who might be already prescribed an opioid, again, the reason for the distinction is partly to keep patients from getting into that forced taper situation, where with the prior guidelines saying, hey, don't go over 90 MME and think about tapering people, was part of some of that verbiage. That's been refined. There is in the full, again, there are 12 kind of bullet points of the current CDC guidelines, and I've got them a little later. We'll kind of talk through them toward the end of kind of what exactly they are. But again, they leave out any numbers. So there are references to numbers in the text. If you dive into the 200 plus page text, certainly to talk about the studies, to talk about specific information. There's mention of numbers, but there's no hard recommendations in that regard. All right, and so expanding on that tapering idea, there is expansion on the whole question around tapering. And again, that forced tapers are discouraged. We do have data now that really didn't exist in 2016, where there have been several papers that have come out showing increased, if a patient involuntarily tapers by 25 or 50% acutely, they have an association with more emergency department visits over the next 2 years, and more overdoses, more mental health crises. So we think there are significant harms of involuntary opioid tapers, and so those are, frankly, to be avoided. Considerations for dosage. Here in bold, we've got the recommendations related to opioid dosages are not intended to be inflexible, rigid standards of care. They're intended to be guideposts to help inform clinician-patient decision-making. And so I think that says a lot right there. So dosage guidance has been updated regarding the lowest starting point for opioid naive patients, milligram morphine equivalent doses, and approach to potential for dose increases, et cetera. Also, there's a bigger section on non-opioid therapies. Excuse me. That again, that really just wasn't even included, but I think to help clinicians feel more more comfortable with some of the non-opioid therapies that are out there, the guidelines do mention that, hey, in many cases for dental pain, for certain types of acute injuries, there will be times that a combination, particularly of an NSAID and acetaminophen, can be as effective as an opioid. So that data is there and is described, and hopefully will be something clinicians will try to incorporate into their practice if they can. All right, and so the 12 guidelines that I've got. This is the abbreviated version. This is the updated 2022 version. They're almost exactly the same. There are a couple that are different. And this is kind of a summary, and I've actually got the full written out slides just out a little further. And so again, the guidelines overall, non-opioid treatments are often effective, that we should, in addition to any opioid treatment, also maximize non-opioid treatments and discussing benefits and risks, starting with immediate release rather than long-acting opioids. We should use the lowest effective dose, evaluating risks and benefits. And again, there's no mention of the milligram morphine equivalent concept or any hard numbers in the full list of recommendations. They are in the text, not deep, but they are in the text, of course, because they are the data, but they're not part of the main recommendation. For patients already receiving opioid therapy, carefully weighing the risk versus the benefit, using care and changing the doses. Number 6 is interesting. For acute pain, the concept is the same in terms of staying with the lowest effective dose, but there's no specific number of days anymore. Previously, the guidelines had referred to 3 to 7 days, and that's been removed. This one was interesting to me also as I reviewed this: regular reevaluating risks and benefits of treatment with an opioid. In the prior guidelines, part of reevaluating risks versus benefits, of course, might be seeing the patient in the office. However, in the text, it mentions considering things like social determinants of health, patient's ability to get to an appointment in terms of the frequency of your visit. So perhaps not being rigid in, hey, I have to see you back in 1 week, if that's not realistic for the patient. And then where's the balance of that with wanting to reassess sooner than later, but also keeping in mind the social determinants of health and how that's going to impact that patient overall. Will it end up disqualifying certain patients from therapy? And is that something we should think about? I think that's, again, something I'm kind of thinking through myself. Also, ongoing ongoing evaluation of the risks of harm and offering naloxone, reviewing the PDMP data, considering risks and benefits of toxicology testing. There's no strict threshold mentioned of how many toxicology tests that you have to do or don't do, just that you're considering it as part of the CDC guideline is all. I think this is big also. Number 11, using caution if patients are prescribed opioids and benzodiazepines together. So the old verbiage, it said avoid. And so as we all know, giving that avoid was creating a lot of room for insurance companies or pharmacies to have challenges related to all of that. So it's not that you can't use those two types together. It's just it should be done very cautiously. And finally, offer or arrange evidence-based treatment of opioid use disorder. One of the feedback items that came in regards to recommendation number 12 was, of course, offer or arrange very often. Buprenorphine was mentioned again, because as a outpatient prescriber, many of us are able to prescribe buprenorphine, and that's an option. The current recommendations make sure to mention methadone, which is very effective and has, a very strong base of data for its effectiveness, and then reiterating that detoxification on its own without medication is not recommended because of the risks of overdose and death. All right. I just put a couple of these references, some of these websites that we pulled from, and the papers have their references as well. I like this one too. On the plus side, you've cured my back pain, says the dog to the porcupine, as he has a whole nose full of quills. So I think that's most of what I have to say. I have the guidelines, in full CDC version written out here on a couple of slides just to go to if people wanted to review that. I mean, and I can read them to you, but you can read them also. So I think at this point, I'd just like to pause and see what kind of questions people might have or cases. And again, like I said, I kind of intentionally have these specific slides here with the actual written recommendations in case somebody has like a super granular question on something like that.
Thank you so much, Dr. Merritt. I'm not seeing any questions right now, but I do encourage everyone, since your microphone and camera is off, to enter those into the chat. It looks like one was just entered, and that question is, were there any recommendations regarding the use of opiates and muscle relaxants or gabapentin? Sometimes we get notice from insurance about risks of these medications in combination. I even received a notice recently of risks of opiates with Cymbalta.
Yeah, that's interesting. Yes, and I think that might be here. Recommendations 8, 9, 10, and 12. So again, the guidelines kind of put them together under some different headings, and actually this one is that. So clinicians should use caution when prescribing opioid pain medication and benzodiazepines concurrently, and consider whether benefits outweigh the risks of opioids and other central nervous system depressants. So I think, being that gabapentin is a central nervous system depressant, Lyrica, many antidepressant medications fall into that class, I think it's possible that we may still continue to get some of those notifications. I think that is true. And I believe the data in regards to gabapentin, I think, is changing. I would say when I was in training, there was an idea that gabapentin was very benign and kind of no big deal. And then maybe, again, in the last 10 or almost 15 years, more recently, there are studies showing there are many people who do use gabapentin or misuse gabapentin. That doesn't mean your patient that you're prescribing it to is misusing it, but it is associated with more opioid deaths, I think, than was previously appreciated, and associated with just being that maybe it's in the system of the person who experiences an overdose event, not necessarily that we're able to blame the one particular compound, but I think the association is what we have, just that we're seeing that.
Awesome. Thank you. We definitely just got a flood of questions, so I am going to say, going forward, Dr. Merritt, if you think any of these questions are super specific and you'd prefer to follow up as a one-on-one max call, please feel free to determine that. But the next question I'm seeing is, how is a low volume of prescriptions for controlled substances determined? You are not required to obtain a waiver or prescribe electronically under the following exceptions. The prescription is issued by a health practitioner who writes a low volume of prescriptions for controlled substances as determined by the Maryland Healthcare Commission. That's a long one. Let me know if you need.
Yeah, I get the question, but I don't think I have that answer. Yeah, thank you for that. So yeah, let's follow up after this call in regards to that, because I'm sure there are prescribers and practices that would meet that threshold, but I just don't have that information myself.
Okay, thank you. The next question I'm seeing is, we are calling in from the GBMC residency program. We do have residents for 1st to 3rd years. Can you please go over initiation and MME?
Sure. Yeah, so MME is a milligram morphine equivalent. It's the idea that, that we need a common denominator of the different opioid drugs to be able to convert to know how much one is versus another. I do have the CDC puts out an opioid calculator app. For iOS is what I use. If you just look up App Store CDC, there's an opioid calculator. That's the one I use. And if you're doing inpatient work, converting people from IV to PO or converting between opioids, an opioid calculator is helpful. So that's kind of what that concept is and how you might use it. If somebody's, this person's getting 4 milligrams of hydromorphone twice a day on their PCA, or, over 12 hours on their PCA, how am I going to convert that to PO? Well, you could use an opioid calculator and do that. So I think if you're a resident, that's a valuable tool to know about, to find one that works for you. Some of them are just web pages that you can save as a thing on your home screen. The MME question, and then what was the other one? Oh yeah, initiating. Yeah, it's hard to know, and this is where practices differ between doctors. There are, if you're treating acute pain in particular, if you're internal medicine residents, and I don't know how often you deal with post-op patients, but there actually are some recommendations out there that we could send as a follow-up for post-op pain. Some of the societies, and actually Johns Hopkins, Dr. Marty Macri has put together some of those, where they looked at, 100 people that had their gallbladder out, how many opioids did they take, and made the bell curve of how many did everybody take? And it was, 6 that you took. On average, people took 6 5 milligram oxycodone, for instance. I'm making it up, but it's low. It's lower than you think. And when some of those papers first came out, many surgeons were like, wow, I just write everybody 30 because that's a good number. And then they don't call you for any follow-up. And so that's, some of that is part of why we are where we are with the opioid epidemic, really, is because it makes sense the way the healthcare system is set up to overprescribe almost if you're discharging a patient, right? So it can be very, very challenging in that way. So maybe my real answer, well, so how would I really decide, doctor, how much to give somebody would be if I had an inpatient, looking at what they've taken, looking at when they're going to be back, and trying to find the lowest effective dose. And then, having them have a backup plan. How are they going to call me? How are they going to call their primary? Are we going to set them up with pain management in a couple weeks, if that's possible? I think all those things.
Awesome. Thank you. The next question I'm seeing is, can you provide more information on how to use caution with an opioid agonist or partial agonist prescription and a benzodiazepine prescription? Are there more guidelines on assessing risks and benefits?
Yeah, that's a good question. I don't know off the top of my head about specific guidelines assessing risks and benefits. I mean, I think we all know that, oversedation respiratory depression is the risk. It's going to be higher with higher doses. There's probably more risk with longer acting agents. So a patient with a long acting opioid, for instance, and I believe methadone specifically, there is some data around more overdose events in patients with on methadone and methadone and sleep apnea. So if we're talking about using caution, it might even be a matter of, as the clinician, I'm thinking through, is that patient an overweight person who has sleep apnea? how do I use caution? Do I help them lose weight? Do I make sure they have a CPAP? Do I call their benzodiazepine prescriber and try to have a conversation about if there are alternatives? I think, and then documenting, right? So using caution is somewhat how you think, and a lot of how you document, just that you take into consideration different factors, and that you maybe discuss also with the patient. Hey, the risks of these two medications include XYZ, and I just want to make sure that we've discussed it. And I think patients who've been prescribed and co-prescribed maybe these two classes of medications for a long time, very often you'll have that conversation and you'll hear like, oh, well, doc, it's fine. I've been on it forever, and I'll tend to follow that up with, well, bodies change and we're all aging, and that we need to keep revisiting this. And then I think sometimes there'll be a level of improved understanding for why we might need to continue to revisit these things.
Awesome. Thank you. This question came in a while ago, so I apologize to the asker. I just missed it. But the question is, what would be an example of involuntary opioid tapering? Would incarceration be an example of this?
Sure. Yeah, I think incarceration, maybe. I think more often what that looks like is a doctor has been writing a certain dose of opioids for a patient for a while, and then they get spooked because of a change in the CDC guidelines, or feeling like they're under surveillance for some reason, and then the prescriber maybe unilaterally decides, hey, we're going to change your medication, and the patient does not desire a change. That would be like an example of a forced taper, where it's if a doctor-patient relationship is a two-sided thing, where it's a one-sided decision. And in the best cases, if we can work collaboratively with our patients, we can work together with patients. Hey, wouldn't you like to take less medication? Wouldn't it be good to be on less? That's a conversation that can take a while, and you have to kind of keep revisiting that and making small changes. And in the setting of a patient who wants to taper, patients with chronic pain often will do very well and actually report similar pain scores on lower doses of opioids. But in those studies where they've been able to show that, where the patient has a similar pain score on a lower dose of opioids, they're always voluntary. It's always voluntary. It's the patient's choice. It's never because the doctor said, you're going to feel better on less opioids, because it doesn't actually work that way. But if the patient wants to, very often, my pain is similar. And if the patient is at that point, they can often make some tapering. But yeah, forced taper is usually involuntary, like that. Or sometimes if a prescriber's been lost their license, or something like that, we'll talk about those patients as having been forced tapered just by losing their prescriber.
Got it. Thank you so much. I know we are throwing a lot of questions at you, but this is a great discussion and we appreciate all of your answers. I am seeing a couple more questions. Our next question is, if a patient overdoses on opioid and benzos twice, what do you do?
It's a good question. Call Max for a consult. That's a good question. I would need to know a lot, but if I were, how would I be thinking about this if this were my patient? We've certainly had, patients in our practice, or in fact, I can think of a patient that I took over recently who had an overdose event, requesting to continue her medication. And frankly, we've had folks go both ways. Usually in those cases, the couple people I can think of where we've treated, I don't know that they've had 2 overdose events, but that have had 1, we've tried converting them to buprenorphine, and we've at least tried. And I think that's like the exercise of caution. And I think with these 2 people I can think of, the one has done great, and she's on buprenorphine and she feels better. And she functions and she's a nurse. And the one did not do well. And so we can't always prejudge, but there's a lot of just documentation that goes into that. So I guess I would just share that, you know, as a clinician, right? Like, it doesn't maybe always mean you have to cut off all of those medications, but that you probably need to think about a safer medication. And probably in this 2-event scenario where there's been an opioid and a benzo, you know, for sure, I would be trying to get a hold of that benzodiazepine prescriber. You know, who is that? Why do they need this benzodiazepine? Could the dose be lower? You know, I don't know if we have data about forced taper of benzodiazepines landing people in the hospital or causing suicides, but you know, it does for opioids for sure. And certainly, you know, for benzodiazepine taper in its own, you know, needs to be done cautiously because of the medical risks of it. But it can be done.
Awesome. Thank you. This next question, an attendee is kind of expressing their frustration with working with a pharmacy that had pushed back MAT or methadone. Do you have any advice with maybe working with pharmacists, or have you ever had this happen, or just any way this prescriber could work with pharmacists differently to kind of get them on the same page?
And this is a patient who takes methadone or
if that person could just provide a little more clarification, just to read the exact message. They said, is there a way to educate the pharmacist too? I had pharmacy push back for doing MAT or methadone, very judgmental, such that they seemed they wanted to report me.
oh, right, for treating, yeah, for treating people with buprenorphine, right? Like that's like not a good idea. Yeah, I think Bridget, pharmacists are invited on this talk, aren't they? I mean, you know, maybe we need to get more pharmacists on our list here. Yeah, I think it's challenging. I have certainly made calls to pharmacists. I've certainly made calls to pharmacists in the past to have those conversations. I can tell you, I talked to someone at Maryland Medicaid today about my patient who I prescribe buprenorphine 2 milligrams twice a day for pain and an oxycodone twice a day for pain. And she's a high utilizer. And man, if I changed her meds, she'd be in the ER all the time. And she's already like there pretty much because she has a bunch of other stuff. It sounds like you're trying to have a conversation with the pharmacist. I would be glad to, you know, I bet we could we provide prescribers with like a max resource even, you know, could we offer to have prescribers refer reluctant pharmacists to us? I don't know. But I you know, I think that's, you know, Max is looking for ways to educate. That's like part of our mission. So it seems to me there might be a win-win there where if we could maybe provide some literature or a web link or something. But yeah, I think it's challenging. So Maryland Medicaid will flag those bup and opioid combos because that's just what their metric is. In the conversation I had, the pharmacist I spoke with told me, yes, this is like a CMS mandated program we have to do, and this is like part of it. And she was able to, once we had a conversation, say she could look a little more carefully under things that were in my name just because I had made the call. But I think anyone else could get the same result by making a call. Yeah, and I do think, you know, what you might be noticing actually in this case is bias against people with substance use disorder, right? I mean, I think, you know, bias against these folks, you know, people should just stop using drugs, right? Just stop, and you don't need any treatment, and, you know, this is just bad. And it's that kind of voice that is not helpful.
Yeah, thank you so much. I know a lot of our technical assistance resources in 2022 were dedicated to site visits with pharmacists. We at Max don't have much of an authority to require people to come, but we do reach out to pharmacists, invite them to our webinars. So we've seen that, but we've also seen on the other side of the spectrum, pharmacists who are really dedicated and who have engaged in our services. So I do believe that there is a possibility that we can all get on the same page at that, but I do think it's a great topic that was brought up.
And really just the idea, this is like a life-saving therapy that like we cannot do without them, right? Like, oh my gosh, you're so important. Like you need to do this with us because, you know, we're saving lives and we're helping people recover. And
exactly, yeah. Thank you so much. We have 3 minutes left. There are a handful of questions that we probably won't be able to get to, but I will make sure that they are relayed to Dr. Merritt after today, just so you are followed up with directly and are able to get an answer. We also, just going back to that last point, we also have something I definitely should have mentioned is one of our consultants is a pharmacist, Bethany DePaula.
yes.
She's awesome at answering calls. I think definitely that's a concern that people have called into the line with before is getting pushback from pharmacists, and Bethany has been connected with them and has kind of walked that provider through the best way to approach that that pharmacy. So that's something we're definitely still working on and developing, but we see the need for it. And I think Dr. Merritt made some great points about that too. But we have definitely exhausted Dr. Merritt's efforts on today's webinar. So I will follow up with all those other questions that are still lingering out there individually. And I'll make sure that even if Dr. Merritt cannot answer them, since there are a lot, we'll connect you to another one of our expert consultants. But thank you all for being online for us today. And just one more huge thank you to Dr. Merritt for presenting today. Thank you everyone who has been online, and thank you to our partners, the Anne Arundel Health Department and Baltimore County Health Department. Look out for those resources. They also may be contacting you directly just about other more county specific resources that they can offer. Other than that, just look out for any follow-up emails. If you did email me about any technical issues, I did respond, so please look out for that. Other than that, fill out that evaluation survey, give us 1 week to process your attendance, and then look out for your certificate to that same email you registered with. Thank you all.
All right. Thank you. Thanks, Bridget. Thanks, everybody.
Yeah, feel free to log off. I'm just going to be saving everything that needs to be saved.
Very good.